let me thank the few brave ones who are here with us. And first of all, let me say that today I'm going to talk about the contact lens-related keratitis, some indications for this pathology that is becoming increasingly common and increasingly working even from the forensic viewpoint. So the cases of keratitis related to contact lenses where has been reported with an incidence of 1 out of 2,500 contact lens wearers for those who wear daily contact lenses and a higher rate of incidence for those who wear them more frequently. Okay, there are differences between soft lenses with a protracted and prolonged wearing and for myopia, and then this report. And these cases were reported in a long time, whereas in patients who have been sleeping and swimmed with the contact lenses. So very often the pathogen agents hasn't been recognized. But we should always remember that it is very important to instruct correctly our patients. So if we have a patient wearing contact lenses, we should always remember that if daily contact lenses are used, they should be worn for no more than 1 day, and particular attention is necessary when the contact lenses are worn on the seaside and the swimming pool and or while having a bath. So not using these contact lenses on those occasions or wearing masks. So these are the cases of microbial keratitis on contact lenses wearers, and you may see the incidence in North America and in Italy. The bacteria which are most frequently associated to this kind of keratitis are especially gram-positive, gram-negative bacteria, but actually in most reviews it is reported that amongst the gram-negative bacteria, it's especially Pseudomonas and then Acanthamoeba and fungal keratitis that are less frequent than bacterial keratitis, but are closely related to contact lenses. So the microbial ones are subdivided into Acanthamoeba and fungal and bacterial. Acanthamoeba is particularly common, and trauma are found in all groups. In particular, fungal keratitis in this group, and also ocular surface diseases may cause microbial keratitis. This table is quite interesting, I believe, because it distinguishes between bacterial, fungal, and Acanthamoeba keratitis on the basis of symptoms. So the main difference being that in fungal keratitis, we have a slower onset of symptoms, so we may be confronted with cases that at the very beginning might go unnoticed or might be taken for foreign body lesion, or then in the end we might find out that it's a very severe fungal keratitis. And then you may see also vegetative trauma, and the difference in terms of outcome depending on when the diagnosis has been made. So for fungal keratitis and Acanthamoeba keratitis, the time necessary is particularly important. An early diagnosis certainly ensures a better visual outcome, especially when it comes to Acanthamoeba. And you can also see the difference in financial costs. I hope that you may see it looks better than that seems to me, says the speaker. However, there are cases when no microorganisms can actually be identified. These are the risk factors, and you may see that the need to hospitalize these patients has considerably decreased. In this table, we may see for acanthamoeba the symptoms that may be found and observed at an early stage. It's more than symptoms, it's the clinical picture here, and then what can be observed at a late diagnosis. At the beginning, it's mainly punctate keratitis, so this point-like picture that might even lead to a misdiagnosis, whereas when in the other one we have the typical epithelial losses and the ring shape. This is a case of an 18-year-old guy who had this shape, how to say, but he used to wear contact lenses. So this has guided our diagnosis because there was also pain. So we immediately thought of acanthamoeba, and we used propamidine drops that, luckily enough, was available in the Vatican City pharmacy. And so we have seen a progressive resolution in a matter of 2 months. But unfortunately, these cases have to be closely monitored and followed up. And one should be very, very patient. But if you do so, you may have incredible results, as it is shown in these slides. Then we will hear from other speakers that there are many devices that can help us diagnose confocal microscopy, especially for acanthamoeba and fungal keratitis, especially. But I think that since each of us might be faced sooner or later with a situation where it isn't easy to perform a more sophisticated exam or test, so certainly we have culture tests. It should be done, especially if we see no improvement in a matter of days. But we should also learn how to clinically identify these keratitis and rapidly diagnose them. And then we will cultivate cells and confirm or reject the diagnosis. This is another boy, 22 years old, and here it's the picture is more or less after 2 months. This isn't the final resolution. This is a girl. First diagnosis hepatic keratitis. It had been confirmed by the PCR and the culture test, and this is the resolution in 3 months. This is again a contact lens wearer. This is a keratitis that actually did not respond to any possible treatment. At the beginning was diagnosed as herpetic in nature, and so no antibacterial actually worked, and so we initially thought of fungal disease, and gentamicin drops have been used on top of the standard treatment, and the situation resolved in 3 months. This is acanthamoeba, again clinical and PCR diagnosis, and resolved in 4 months. This is also non-responsive to treatment. This is bacterial keratitis. And then we had the resolution in a matter of 3 months. By way of conclusion, it is absolutely crucial to analyze the risk factors and clinical features, but also to try and assume and what the agent might be. In our opinion, hospitalization is not necessary unless there is a very large involvement of the anterior segment and possible perforation or scleral involvement, but they should be closely followed up. But for acanthamoeba fungal keratitis, the healing process is very slow, so we shouldn't get scared when we don't see an immediate resolution.